Hello, my name is Rupa Ghosh-Berkebile, and I'm going to be talking to you today about cancer survivorship care. A little bit about me. I am a nurse practitioner in the supportive care clinic at the Arthur G. James Cancer Hospital in Columbus, Ohio. I am part of a dedicated interdisciplinary team that does cancer survivorship care. In addition to my survivorship experience, I have experience in inpatient medical oncology with all solid tumors and bone and soft tissue sarcoma. So today we have a few goals of our presentation. I want to start by giving you some trends and defining cancer survivorship care and what it is and maybe what it isn't. I will kind of take you through what is involved in a treatment summary in a survivorship care plan. We'll talk a little about late and long-term effects, both kind of general ones that most cancer survivors face, and then a few that are specific to gastric and GE junction cancers. We'll talk a little bit about some coping challenges that can happen during the cancer experience, and then basically survivorship in action. I'll tell you a little bit about our clinic. So why is this important? Why is survivorship care important? So as of 2019, there were 16.9 million survivors in the US. This number is continuing to go up, and by 2030, they project that there'll be 22.1 million survivors. The top 5 diagnoses are breast, prostate, uterine, colon and rectum, and melanoma of skin. And the majority of survivors were diagnosed less than 10 years ago. However, 18% of survivors are living more than 20 years after their diagnosis. So that kind of brings me to my next point. There's this thing called the Silver Tsunami. And what this basically means is that 64% of our survivors are now 65 years or older. And why is, and we think that by 2040, 73% of those cancer survivors will be 65 years or older. So why is that? Well, we have an aging baby boomer population. As you know, we have more research, which means better drugs, better outcomes, better survival. People are living longer. We have improved methods of early detection and prevention, but this also comes with a downside. These people who are aging, they are already aging with some other comorbidities, whether it be obesity or high cholesterol or heart disease. And when you add on the long-term toxic effects of cancer treatment and the fact that some of these patients are going to be taking medication for a very long time, they will actually appear sicker than their non-cancer colleague at the same age. We've found that half of cancer survivors between the ages of 70 and 74 have a history of other health problems or comorbidities, as I mentioned, prior to their cancer diagnosis. Of these cancer patients, lung cancer patients seem to have the highest risk of other diseases. So basically what I'm saying is that the physical age is not going to match their chronological age. So basically, as you can see, the time is now. We need to do a better job of taking care of our cancer patients after they finish treatment, because just because you're done with the treatment themselves, as I'm sure many of you realize, it doesn't necessarily mean you're done with some of the after effects that the treatment causes. So we have a rapidly growing population of survivors who have complex needs, and each different phase of the cancer experience continuum have different needs, different skill sets, different healthcare providers. The whole point of this, though, is to increase the emphasis on better quality of life in addition to better cancer outcomes. We want you to live longer, but we want you to live well. And so survivorship care really is putting a greater emphasis on patient care and patient-centered issues. So, what is the definition of a cancer survivor and cancer survivorship? Cancer survivorship begins at diagnosis, and it continues throughout a person's lifetime. So it doesn't necessarily mean, survivorship doesn't necessarily mean that you've crossed the finish line. Treatment may or may not be done, but some of the effects of the treatment may linger. Previous definitions you may have heard are actually incorrect. People have said, oh, well, if you're not disease-free or disease-free for 1, 2, 5, 10 years, you're not a cancer survivor. Or if your disease comes back, you're no longer a cancer survivor. That's not true. You are a survivor as long as you walk this earth. Now, we know that cancer affects people in multiple different ways: physical, emotional, mental, financial. It also affects their families and the relationships they have. And we're going to talk a little more about that later. But no two people are the same. The needs are unique to every patient. So there's a spectrum. It used to be there were 3 different seasons of survivorship. Well, that has evolved into this spectrum because, as you can see, you can have many different kinds of survivors. Someone could be living cancer-free for the remainder of their life. Maybe they've lived cancer-free for many years, but they have some late complication of treatment. They could have been cancer-free for a long time and then get a recurrence, which is the thing that takes their life. They may develop a second cancer. They could live with intermittent periods of, okay, the cancer's back, let's treat it. Okay, it's gone again, it's back. So intermittent periods of active disease. And then we have patients for whom treatment's never going to end. They're going to be getting lifelong treatment, managing this much like you would manage a chronic disease. So as you can see, each stage of this is going to have very unique needs and challenges for both patients, caregivers, and providers. And it is our duty to help meet those challenges. So I'm going to take you back, brief history lesson. Hopefully this isn't old information for you. But basically, the idea of survivorship started with a physician in 1985 who himself was a cancer survivor. And he basically wrote a piece for the New England Journal of Medicine that defined the survivorship movement. He described his own physical and emotional struggles with his cancer, and it led him to believe that, for better or for worse, or better and for worse, physically and emotionally, the experience leaves an impression. No matter how long we live, cancer patients are survivors, at once wary and relieved, bashful and proud. End quote. So also in this essay was this quote, which really kind of exemplifies the reason that survivorship care got started. We have, it's as if we have invented sophisticated techniques to save people from drowning, but once they have been pulled from the water, we leave them on the dock to cough and sputter on their own in the belief that we have done all we can. So basically, it's not enough for us to say, oh, your cancer's gone, we've cured it, we'll see you in 3 months for your scans. We need to do a better job of coming back full circle and making sure that that you have a good quality of life as well. So about a decade later, this document came out from the Institute of Medicine, and it basically is a landmark article or a landmark publication. It was the first document to formally highlight the needs of cancer survivors. Basically, its purpose was to raise the awareness of the medical, functional, and psychosocial consequences of cancer and its treatment. Talk about what's good quality healthcare for our survivors, and how do we achieve that, And as I've said a lot, it's really about improving quality of life by making sure services are available for anything that the survivor might need. Now, before we go much further, you've heard me use the term survivor a lot. As a field, we call it cancer survivorship, but we are all fully aware that not everybody likes to refer to themselves as survivor. They'll refer themselves as thriver, warrior. There's a lot of different terms people use. The one I kind of like people to avoid is victim, but I think anything you use to refer yourself that empowers you to live your best life is fine. I will probably use the term survivor just because that's a catch-all and it is cancer survivorship care, but by no means does that mean you have to call yourself that if that doesn't work for you. Okay, moving on. So in 2016, we finally got some accreditation standards from the Commission on Cancer. They added survivorship care to the requirements for accreditation. And at that time, their focus was on providing patients who completed treatment with a treatment summary and care plan. And they had metrics that we had to meet. We had to, that year, give 25% of our patients plans all the way up. It was supposed to eventually be 100% by 2019. And I think they realized along the way that A, that was a hard standard to achieve for some institutions, but B, survivorship care is a whole lot more than a 3 to 4 page document. So they made a revision in 2019. And now the requirement is the development of a comprehensive multidisciplinary survivorship program to address the needs of cancer survivors. And there should be services that are available on site in a clinic or by referral. And the services should be provided by a dedicated survivorship program team. Some of those services, example-wise, are besides the treatment summary and care plan, which is encouraged now but not required, screening programs, oncology rehab, nutrition, counseling, support groups, an ability to get someone to a cardiologist if they're having cardiac-related effects from chemotherapy, pulmonary, men's and women's health, fertility preservation, financial support services, and an exercise program. And as far as a program team, it could include nurse practitioners, physician assistants, physicians, RNs, social workers, dietitians, physical and occupational therapy, psychologists, psychiatrists. There's several people that could be on that program team. Okay, so let's talk a little about the treatment summary and survivorship care plan. Why do we provide one to our patients? Well, the goal is to empower patients to be knowledgeable regarding their own cancer diagnosis and their treatment. It helps improve the coordination of care with their primary care provider, as well as anybody else on their care team. It helps promote quality of life and living well with or beyond cancer, and it's highly personalized and individualized for the patient. So when should we be doing this? Ideally, we want to provide the treatment summary and survivorship care plan within 1 year of the diagnosis of cancer, but no later than 6 months after the completion of treatment. So what exactly is this? I like to call it a roadmap. Kind of the where we've been and where we're going. So the treatment summary piece is where the survivor has been, and then the rest of it, which is how often you're going to see your team for scans and labs, etc. That's what to expect in the future. So it's a document and it's a visit. Because the end of treatment visit is typically 45 to 60 minutes with a provider to review the plan, to discuss any supportive care or symptom management needs, and make any necessary referrals. We also discuss cancer screenings, vaccinations, and healthy lifestyle recommendations, And this is a time to do a little bit of goal setting to kind of help start the reintegration process, but to set some goals and answer any questions that the survivor might have. This can be done in an office visit, or it can be done via a video telehealth visit. However, it has to be a discussion with the provider. If you are just getting one of these documents in the mail without an appointment and a discussion to go with it, that's not the right way to do this. Because we understand that you're going to have a whole lot of questions and things come up, things that you may not have brought up with your primary team when you were in the middle of active treatment. So there are some required elements. Sometimes there are templates on sites like Journey Forward and through the American Cancer Society, the National Coalition for Cancer Survivorship. So sometimes survivors print those off and they fill stuff in themselves. And they take it and talk to their oncologist about it. But the trend is generally that your team should be doing this for you and scheduling an end of treatment visit for you, either within their clinic or within a dedicated survivorship clinic like we have. So basically, these are the required elements. I'm not going to necessarily go through all of it, except that it's really supposed to be pretty comprehensive. The idea is you're supposed to be able to have kind of a concise document that has all of your treatment on it, kind of what you're supposed to be doing as far as lab scans, etc. So, for instance, I tell some of my patients who like to spend the winter in Florida to take this document with them, because if for some reason they need medical care, that at least gives that hospital, who doesn't know them at all, an idea that, oh yeah, this person's had cancer treatment, they've done this. It helps direct the care. So that's one very useful thing with this. But the first part is the treatment. The next part is we do review family history, because sometimes in doing so, we find trends, in which case we will talk to you a little bit about genetic testing if that's something you want to have done. If you've already had it done, we'll put that on the care plan and talk a little about the results. So as far as latent long-term effects, it's a cancer specific, but then we go into more general ones as well. A word about screenings. Screenings are really important, because having a cancer diagnosis and some of the cancer treatments we they actually put people at a higher risk for new primary cancers. So I mention this because when you're in this phase, it's time to get those back in, because often they're the first thing to be postponed when you are diagnosed and you're going through treatment. Totally appropriate, but then after you're done with treatment, you need to go back and restart those screenings again. So who typically creates and delivers this care plan? As I mentioned, creating the care plan really should be done by the team or center that did the treatment. Now, if you had treatment in 2 different centers, hopefully you coordinate. You don't get 2 separate care plans, you'll get one, and one of the institutions or the other should be getting the records and consolidating everything. As I mentioned, it can be done in an office visit or via video telehealth, but it requires a discussion with the provider. And then copies of it will go to your primary care and your entire care team. If you think about your primary care physician, they're like the hub of a wheel. And any consultant, your oncologist, your surgeon, your radiation oncologist, they're all spokes of the wheel. So really, your primary care provider should be in the know about your cancer care. So this plan can be delivered by a lot of different people. Typically, it tends to fall to a nurse practitioner or a physician assistant. because they can prescribe medication if necessary. They can make those referrals as well, but sometimes nurse navigators will do it, and sometimes the nurse navigator is an advanced practice nurse. Physicians can do it as well. In rare circumstances, we see registered nurses doing them, but as I mentioned, if a referral needs to be made or if a medication needs to be prescribed, that's why the registered nurse is limited. They have to, they can't prescribe. And once this is done, this document should live in the electronic health record. Okay, so I'm going to go a little more in depth as far as that last section of the care plan with late and long-term effects, because I think this is really important. This is a big part of why survivorship care has come into being. So after you finish treatment and perhaps you get a certificate that you finished chemotherapy, or you ring the bell at radiation therapy, a lot of times people come see me and I hear, well, now what? They've gone through this routine of seeing people regularly and having someone checking in on them, and then all of a sudden it's okay, we'll see you in 3 months. And they're like, okay, but I still have so many questions. So as you can see, this guy, fertility, pain, body image, fatigue, all sorts of things that have come up or have been put on hold and are now coming to the forefront again. So as far as late and long-term effects, I'm not going to go through all of these, but I wanted to let you know that it affects every system, and it affects you emotionally as well. So that's what this is really meant to demonstrate. It does not mean that you will have every single one of these late or long-term effects, but it does mean that they exist. 50% of patients have at least one long-term or late effect. And just really quickly, the difference. A long-term effect is a problem that started during your treatment and may continue for months or years. And a late effect is something that is still caused by your treatment, but may occur months to years after you're done. So I highlighted 4 of the most common ones that I tend to hear about: fatigue, pain, depression, and neuropathy. So I'm going to start with fatigue because it is the most common complaint of cancer survivors. It is most prevalent in the first 5 years after treatment. It is different than other types of fatigue as it is not typically relieved when you rest. So what can contribute to fatigue? Well, we first want to rule out medical causes. Check your thyroid function, make sure it's okay, because there are several medications and treatments that can cause hypothyroidism. Want to make sure you're not anemic. We want to make sure that things like your potassium, your sodium, and your magnesium are all balanced. And then some medications such as antidepressants, some blood pressure medicines, they can actually cause fatigue as well. If you're not sleeping well, even if you get the 7 to 9 hours that we recommend, but you don't wake up feeling refreshed, then you're not getting good quality sleep. So it's about quantity and quality. That can contribute to fatigue, and then depression can actually contribute to fatigue as well. So what can we do to help fix this? The one research-proven intervention is exercise, ideally aerobic exercise. But the thing with that, you have to be careful. If you do nothing, you're going to be tired, and if you do too much that your body's not ready for, you're going to be tired. You'll make your fatigue worse. So the key here is graded increases in your activity level. We do know now with several cancers that physical activity is associated with a lower risk of recurrence. The recommendation, the gold standard, is 150 minutes of moderate level aerobic activity a week. So you might break a sweat, you might be able to talk but not carry on a really long conversation. That's the level of intensity. So In addition to that, though, it's daily stretching and 2 days of resistance training as well. This is the gold standard. A lot of people cannot start there. So I typically tell people, start with walking. That's kind of a basic thing. It's cheap, it's easy, you can do it anywhere, and you can time it too. You don't have to walk super fast, you just have to walk for time. Start with 10 minutes and see how that goes. And if that goes well, increase it by 5-minute increments, or put another 10-minute session in later in the day until you're walking about 30 minutes a day. One team that can be very helpful as far as fatigue management is our physical and occupational therapists. The physical therapist can help you get stronger and help kind of figure out where you need to start and how you need to progress. But our occupational therapists, they can help kind of with what I call life hacks. So they can help with the how do you manage your time, how to learn to take breaks, how to organize your day based on when your energy level is the highest, things like that. There is some evidence about psychostimulants, but it's very, very limited, and honestly, we don't use them to help manage fatigue. Okay, so next I want to talk a little bit about pain. Because as you know, you may have had pain during active treatment, but sometimes the interventions that we do to get rid of your cancer can leave you with a chronic pain syndrome. So about a third of cancer survivors report ongoing pain at 5 years versus 5 to 30% of the general population. Now, it's important to know that not all pain is related to cancer recurrence, but oftentimes that's where your mind goes first. So it is important to report it to your cancer care team so that they can work it up thoroughly, because the first thing we're going to do is rule it out. But once cancer has been ruled out as a cause, there are several things you can try before or in addition to medication. Heat, cold, this is where physical therapy or aquatic therapy can be very helpful. Exercise, again, is very helpful. Massage or acupressure or acupuncture. So, sorry, this is a little bit busy, but basically not all pain is treated the same. Things that work for one type of pain may not work so well for other types of pain. So that's what this is meant to sort of illustrate, is that, for instance, nerve-related pain or neuropathic pain, we can use duloxetine or Cymbalta to help treat it, or we can use gabapentin or Lyrica. You can also use massage, physical therapy, acupuncture, music therapy, guided imagery. We do also have, if you have a pain management or palliative medicine team, they're ideal to help get involved. Sometimes we'll send people to our physical medicine and rehab physician, kind of like a functional physician, who will talk about nerve blocks. So if that's what it takes. But as you can see, there's a lot of different things you can do depending on where the pain's coming from or what the cause is. So as far as specific things for gastric or GE junction cancers, I'm thinking that I'm hoping some of this may be review, but we know that weight loss, diarrhea or dumping syndrome, neuropathy, as we talked about from chemotherapy, lifelong vitamin or mineral deficiencies in B12, D, and iron, and then reflux or GERD, or some long-term effects, and then some late effects, depending on the chemotherapy drugs you received, you can get some cardiac issues. And then because you're now deficient in vitamin D, it puts you at a higher risk for osteoporosis. So as far as some of the interventions to help with the late and long-term effects of gastric and GE junction cancer, I would definitely recommend meeting with a dietitian more than once if needed for nutritional guidance as you're learning what works and what doesn't. You need to monitor your weight regularly to make sure you're not losing weight. Watching for signs of dumping syndrome, which basically there's the early dumping syndrome and the late dumping syndrome. It's usually after you've eaten a bigger meal than your stomach can handle. And early is like about a half hour after you eat, and it's you feel like your heart's beating out of your chest, you're nauseous, you have diarrhea or cramping, but then it can happen 2 to 3 hours later too, and that's usually when you get dizzy, extreme hunger, cold sweats, and you might feel like you're going to faint. So the way we kind of avoid that, usually if you've experienced it once, you've learned your lesson and you will never let that happen again. This is what I've been told. But it's better after surgery to actually eat 5 to 6 small meals per day. Eat very slowly, chew your food well. Don't drink a lot of fluids with your meals because that's going to fill you up instead of the nutrition, and then you're going to lose weight. Now with all of this, it may change your social interactions with people, especially if you're used to gathering and eating out. It may change how you do things, and it may take you a little bit to figure out how to handle these situations. As I mentioned, you get lifelong vitamin B12 and vitamin D supplementation. The way to kind of help avoid osteoporosis is weight-bearing exercise and the supplementation and bone density screenings, perhaps starting earlier, but definitely getting them every year or every 2 years. Also regularly monitoring labs to make sure those levels are where they should be. As far as the reflux, you want to avoid acidic or spicy foods, alcohol, smoking, and then anything that relaxes the esophageal sphincter. So things like peppermint, chocolate, caffeine, those can sometimes worsen reflux. And then as far as the diarrhea goes, sometimes bulk forming agents such as Metamucil or Imodium are helpful. Okay, so this is sometimes the hardest part of survivorship. There are coping challenges. So we typically call it distress. And what is distress? Basically, it covers a lot of different things. Psychological, whether it be changes in thinking, anxiety, or depression. Social, spiritual, financial, or caregiver distress. But the point being that all of these things affect a person's ability to cope with their cancer diagnosis and treatment. So starting with psychological distress, specifically talking about anxiety and depression. Anxiety, it's not uncommon for cancer patients to experience it at some point. What I typically tell people and what I've seen, my experience is that anxiety or uncertainty can ebb and flow. So it may be really high when you're originally diagnosed and you're waiting for the workup and a treatment plan, and then you're starting into treatment. You have a focus, you have a goal, you're sort of in the weeds, I tell people, and you're sort of dealing with the acute issues that are surrounding treatment. But then treatment's done. And again, that sort of now what comes in. And then the first set of scans, it's I don't want my cancer to come back. I hope everything's okay. And sometimes it's not the scan itself, but it's the waiting for the results that's the hardest part. So sometimes I'll see those little spikes of uncertainty, like every 3 months or every 6 months, whenever they're supposed to go in and see their oncology team. So that's what I tell people. It can also peak at what I call times of increased vulnerability. Things like when you're originally diagnosed, like I said, when you're getting your surveillance scans, when you found out that your cancer has progressed, if you're having horrible side effects or not tolerating treatment well. And then for some people, having to make that decision to transfer to palliative care only and not seek any more active treatment. That can also cause a lot of anxiety. But greater than 50% of the uncertainty and anxiety happens in that surveillance phase for people. People, like almost 20% of survivors get treatment-related PTSD symptoms, sometimes just walking in to the hospital, even though you're not walking in for treatment. Just walking into the hospital can bring up some feelings of anxiety. So as you can see, almost half the patients report some form of anxiety. If it's severe, it can interfere with your ability to function, and we don't want that. So it's a matter of trying to manage it and giving you strategies to manage the anxiety when they come up. Now, depression can affect 15 to 25% of patients, but when someone's depressed, it impacts the entire family. However, it's important to know that sometimes physical symptoms can look like depression. For instance, hypothyroidism can look like depression, but it's actually your thyroid. And if you get on medication to fix it, then you might do a lot better. But people who have a long history of anxiety or depression or other mental illness can be very stable, controlled on their medication, and then they get a cancer diagnosis and it sends them out of control again. So that's not an uncommon thing to happen. So social distress, basically, as I mentioned earlier, a cancer diagnosis can touch every aspect of your life, whether you want it to or not. So it can affect relationships with your friends, families, your spouse, or significant other. It can affect it positively or negatively. It can, you may have issues with body image. There may be a role change. You might have been the matriarch or the patriarch or the caregiver, and all of a sudden you've gone from the one taking care of everybody to the one needing to be taken care of, and it can be difficult asking for help. There's some loss and some grieving. Grieving the life you had without cancer. Maybe grieving the loss of independence, whether it's temporary or permanent. The loss of your self-image or future plans for yourself. So it creates a ripple effect. It may start with you, but it kind of goes out to everyone that's in your life. And so everything changes, yet everything stays the same. I liked that better than the new normal because a lot of survivors really don't want to hear that term. But basically, either one is saying your life's not going to necessarily be what it was, but you got to figure out what it's going to be, and it could be something much better. I've had patients have tremendous insight after they're done with their treatment, and they go back to their job, which was highly stressful, and they're like, "Why am I stressing about this? I just beat cancer, or I'm living with that every day," and they'll change their job. They'll change their career completely. So everybody handles things just a little bit differently. But that whole reintegration, I call it the reentry phase, that first year after you're done with treatment, it can be really difficult, especially if you've had a lot of physical changes. And if you're not done with treatment and you're continuing with treatment, it's kind of getting used to that and what it feels like, and kind of that wave of when you're feeling good versus not feeling good. It's important to note, though, that whatever coping strategies you had in place will definitely inform how you cope with a cancer diagnosis. So spiritual distress refers to a way that the person tries to find meaning and purpose in their life and how you connect to others in the world. So some people think of themselves, this is very personal, some people think of themselves as more religious, going to church and routines are important, and others are more spiritual and in their faith. And so it's very much based on personal, cultural, and societal preferences. What you grew up around may influence how you feel. So distress tends to occur, spiritual distress, if there's internal conflict. if you're feeling like God forgot about you, or your higher power doesn't care about you, if you feel like you did something to cause the cancer, the fear of death and dying, and then maybe conflicts between belief and the treatment recommendation. The other thing too is that when someone's diagnosed with cancer, some people use their faith as a source of strength to get them through, and others get angry and think God or their higher power has forsaken them, and they will reject it. So it's like I said, this is probably the most personal of the types of distress there are. All right, a little bit about financial distress. This is a big issue that doesn't often get much press. The term financial toxicity was created because this is very much a toxicity of treatment, just like pain, nausea, vomiting, depression, any of the things we've been talking about. So this term was created in 2013, and is basically the objective financial burden, the medical bills, and the subjective financial distress that it causes for a patient and their family as a result of cancer diagnosis and treatment. It's pretty widespread. Almost 3/4 of cancer survivors experience some form of financial toxicity from cancer care. 38% of patients delayed care, or they didn't adhere to treatment because they couldn't afford it, and they didn't say anything to their team until the next set of restaging scans happened, and they didn't respond to their cancer. And that's usually when they find out that, oh, well, they didn't take this medication the way it was prescribed because they couldn't afford it, or they were trying to make it last longer. The sad thing is that a cancer patient or a cancer survivor is 2.65 times more likely to file bankruptcy than a non-cancer patient. And if that person does file bankruptcy, they have a 79% chance of dying sooner. There is a significant association between financial toxicity and increased anxiety, increased depression, worse quality of life. So lastly, another kind of big issue is caregiver distress. When I said that a cancer survivor, you are one from the beginning of your diagnosis through your entire life, the part I forgot to mention as far as that cancer survivor definition is that it includes caregivers and family. This is a very important person and a very, very hard job. Typically, it's someone who's not paid. They are older than 45, tends to be more female than male. They're less likely to care for themselves because they're focused on caring for their loved ones. And so that makes them more likely to develop other chronic conditions such as heart disease, obesity, diabetes, sometimes even an earlier death because it's pretty stressful. Typically, and this is why, typically they experience increased anxiety, depression, and physical effects that eventually depress the immune system. There's some studies about increase in inflammation as well. So this is not an easy thing. But things to kind of watch for in either if someone's giving you care or if you yourself are the caregiver, if you're starting to become more irritable, more resentful towards the person you're taking care of, if you're starting to have more problems concentrating, you're forgetful, not sleeping well, if you have picked up smoking or increased your smoking, alcohol use, or food consumption, constant feeling of hopelessness or helplessness, if you're getting sick a lot, if you're socially isolating yourself from your friends, and your support system, and you're feeling guilty about taking a break, these are all signs that you might be in distress and you might need help. So, interventions for the cancer survivor as well as the caregiver. Relaxation training or mindfulness. There's a lot of ways to do this. There are 2 really great phone apps out there called Headspace or Calm that you could try, that you can, you know, do first thing in the morning or last thing at night. And they're 5-minute things if that's what you want. And they can be very helpful. Massage, reflexology, or acupuncture. Expressive arts such as music, art, or dance therapy. Knowledge is power. So sometimes getting a little more education about the disease you have can be helpful. Group social support, either in person or online, for both the cancer survivor and the caregiver can be very helpful, as can one-to-one peer support. Counseling can be helpful for both, whether it be with a clinical social worker or a psychologist or a chaplain. And medication can, of course, can always be helpful. However, I will tell you that medication works better if you are in counseling or some sort of support. The other thing specific to caregiver distress is having a team that's caring for your loved one. So if you need a break, you can take one because somebody else is taking over, and you don't have to worry about, you know, the quality of care that your loved one is getting. So a few other resources online that you can check out. The first thing I would do is, if you need help, if you need support, check with your own institution and see what services they offer, because they may have support groups, they may have counselors on staff that can help. And so start there. But if they don't, there's several online resources. The last two are specifically geared towards caregivers, but the first four have information for survivors and caregivers. So lastly, want to talk a little bit about how we kind of do supportive care at the James. And this will be brief only because you'll see as we go through some of these slides, a lot of the things I said we should be doing, we're actually lucky, we're kind of doing it. So our clinic kind of does two things. We do a holistic supportive care needs assessment, and we also provide treatment summaries and care plans. Everybody gets the needs assessment. Right now, our treatment summary and care plans are for people who have completed treatment and are in surveillance. We haven't explored people who've had like metastatic or recurrent disease. But I do think they need a care plan as well. It's just going to look different. So I think there's a lot of research as to what that looks like. So this is our service line. It has expanded a lot since I've been with them. I'm in clinical survivorship, which is basically, as I mentioned at the beginning, an NP-led interdisciplinary clinic with multiple services. So we have oncology rehab, which is our physical and occupational therapists. We have counseling. We also have a psychiatric mental health nurse practitioner that does medication management. Integrative oncology, which is massage and acupuncture. We have fertility preservation. James Care for Life is our patient support and education arm, and they have incredible online and in-person classes, programs, resources. Palliative medicine is our pain management specialists. It also can include physical medicine. Physical medicine kind of also falls in oncology rehab. And then we have our newest merge is patient education. They are now part of the cancer support service line. So this is kind of a summary of our services that we provide. Basically, as you see, remember the Commission on Cancer standard that they want a comprehensive survivorship program with a dedicated team and multiple things for referrals on site, or you can refer out. We do have a team of cardiologists that specialize in late-term effects of cancer treatment on the heart, and so we have that available. We have pulmonary that deals specifically with our cancer patients. We have a nephrologist, kidney person that deals specifically with our cancer patients. So we've got those available, as well as genetic counseling. But in our clinic itself, this is the services we provide. Harm reduction is just, that's not a term that a lot of people have heard. Basically, we screen everyone who comes in to see if they might be at risk for tobacco or alcohol misuse. And if that's the case, we oftentimes will set them up with one of our counselors that has certification in drug and addiction medicine and smoking cessation as well. And so we want people to stop smoking if they can, for lots of reasons. So that's what harm reduction is. So lastly, basically, I kind of like this quote. Everyone has a story, and cancer tried to end my life story, and I decided to write another chapter. And the statue on the left is Hope. She is kind of this, she's in our garden right outside the entrance of the James. And she was sculpted for us by Alfred Tibor, who himself was a Holocaust survivor. And she basically, it symbolizes what we do. Personalized care, and there's always hope. The hope changes, but there's always hope. And with that, I appreciate you listening today. And if you have any questions, please let us know. Thank you.